have Tanisha move down just a little bit.
How do I do this? It's not.
And when you have them in position, scoop forward just like that. That's it. Grab them just proximal to their wrist, and proximal to their elbow, and pull that forward and down. Rest these across their chest like this. Straighten this leg down and bend them here. Now remember, when you're pronating them, if they feel like they're going to fall off, you can just move this so you can get as much tension or lack of tension in the spine. So just remember you can do that. You're going to follow your procedure when you're doing these adjustments. So we'll start with all the PIs. For a straight PI, the first thing you're going to do is bring the patient in, pronate them, stabilize them at about 45 degrees. Okay. Then what you're going to do is use your superior hand, find the PSIS, the inferior portion of the PSIS. Watch your line of drive. It has to come in P day through the pelvis, stabilizing here. That's be your PI. If it's a PIEX, they're not going to be as pronated. Again, you're going to find your contact with your superior hand. Now you're going to be on the inferior lateral portion, and your torque is going to be up the spine like this. If it's a PIIN, you have to pronate them even more. Once they're pronated more, then your spine finger's going to come up somewhat parallel to the spine. You're going to have medial to lateral in your line of drive, and you're going to torque into the spine. Okay, down the joints. Everybody got those? Any questions? Okay, for a straight EX, don't pronate them much. Keep them up here, and your line of fingers are pointing down to the table, just driving primarily lateral to medial with some P to A. If it's a straight IN, you pronate them a whole lot more. Once you have them pronated, your fingers turn back at you this way, stabilizing up here and shoving back medial to lateral. Okay? All right, any questions about those? Okay, for the rest of the pull moves for the ilium, you have your AS. It's 2 inches lateral, 3 inches inferior. ASEX, your fingers are going to be pointing across the spine similar to PI, and your line of drive is going to be P to A, and what you're going to do is you're going to then torque it up the joint like this. If it's an ASIN or an AS, you're going to pronate them more. So for the AS, about 45 degrees, again, find your contact point, superior hand, fingers turn back at you, and you're going to thrust fingers pointing back at you this way. If it's an ASIN, you're going to pronate the patient a little more, maybe move a little bit medial, and then when you torque, you're going to torque down the joint. Okay?
Yeah.
If it's a sacrum, and you're going to do a push move on the sacrum, for the P-L involved side, let's do a P-R, involved side down, or the PI-R, you don't pronate them much, maybe about as much as the PIEX. Find the portion, just the PSIS on the involved side down, set up just medial to the PSIS. You're going to bring your pisiform in there, get up a little bit on the edge so you can put your force in, and the thrust has to come in lateral to medial P to A, and if there's inferiority, you're going to torque it up. Right? Okay, if it's doing involved side up, I want you to just bring the patient strongly pronated, like maybe for a PIIN. In fact, your hand's going to look very similar to a PIIN. You're going to be just medial to the PSIS. You're going to be thrusting back towards you this way, and when you torque, you're torquing into the joint this way, bringing it down. Okay, P to A and medial to lateral. If it's a base posterior sacrum, you can move the patient back and forth this way to delineate and between L5 and S1, so you can make sure you're on S1. Once you find your contact point, bring the patient over to about 45 degrees. Carefully switch hands, put your pisiform right on your contact point, and when you're making your adjustment, get your upstern notch a little bit higher. You're going to lift the bone and shove it inferior. It's this type of a motion. The same works for an S2, S3, S4. Lift the bone, shove it, S to I. Remember, no medial to lateral, lateral to medial on that. It's just straight through. When you're doing a base posterior, an S2, 3, 4, it doesn't matter which side you stand on, just use your inferior hand. Okay? If you're going to do the pull moves, remember the pull moves, the combination pull moves, you want the rotational vector or the rotational component to be the greater misalignment. Some of you understand that from X-ray, some of you haven't gotten there yet. But if you're going to do a PI IN pull move, for instance, you want the IN misalignment to be greater than the PI misalignment. Okay. So let's just say I was going to do a straight IN. You're going to, remember when you're doing all the pull moves, we really don't want our patient to be pronated. We want them to be as perpendicular to the table. Sometimes if you start back a little bit past perpendicular, in the supinated position, it'll help you a little bit. You're just going to stand superior to the bent knee. You're going to come up, you're going to find your contact point. Once you find your contact point, you're going to keep the heel of your hand off of the patient, your thumb planted on the patient, stabilized up here, and you're going to want your elbow down. You want it bent, you want your wrist in flexion. You're going to bring this knee up, take out your slack, thrust. When you thrust, it's the same time as you're straightening your knee. That would be your IN. It's a PIIN, you're going to have to get the inferior portion, so you're going to have a little ulnar deviation in your wrist, maybe move a little bit superior to your patient so that when you thrust, you're going to be pulling it not just lateral to medial, but you're also going to be doing maybe a little I to S, but you're definitely going to torque like that. We don't pull an ASIN. For an ESEX, come just lateral to the PSIS, involve side down. So this would be an EX on the right. Your wrist is going to be in full flexion. You're going to have a lot of tissue between your pisiform and the PSIS, and your thrust is going to come in this way to the patient with a kick. If it's an ASEX, you're going to come 2 inches lateral, 3 inches inferior. Your force is coming in here, and when you're putting your force in through the acetabulum, it has to come in this way now, torquing it down just like this. If it's a PIEX, you're going to start a little bit inferior. You're going to take your tissue pull up to the inferior lateral portion of the PSIS in this direction here, and when you torque, your fingers are going to be moving this direction. I think that's all of them.
Should we review the ones from yesterday?
So just send them to the library.